Kensah. Emmanuel Kensah is an old student, as we have said. He went to SecTech in 1976. He completed his O-level in 1981 and A-level in 1983. He was a very bright student and the best scholar in his sixth form group. He qualified, he has a Bachelor of Medicine and Bachelor of Surgery degrees from the University of Science and Technology in Kumasi. He's been working, he has been working, or he worked at a confidential teaching hospital after his graduation from UST. Completed his general practice vocational training in 2000 at North Staffordshire in the UK. He is a member of the Royal College of General Practitioners, GPs, and has a diploma in obstetrics and gynecology. He has also a diploma in practical dermatology from University of Wales. He also holds a practical diabetes diploma certificate. And clearly he's a very qualified person to speak to us today. Dr. Kensah has had a GP, he opened a GP up in London and in West Bexton area. He currently works with Newham and the transitional practice group that he joined. He's among the very few specialized GPs centers for vulnerable individuals in the UK. That's what he does. He is a senior GP and a very experienced one too. So, ladies and gentlemen, please join me to welcome Dr. Kensah as our speaker for this evening.
Hello, everybody. Steve, thank you very much for that meticulously delivered introduction. I think the only thing I have to correct is that I work in partnership with the then PCT, Primary Care Trust in Newham, to run a single-handed GP practice in West Bexton. And as time has moved on, we've joined with another practice to form a Newham transitional practice. So that's what I'm doing at the moment. Thank you very much. And I also want to say a big thank you to the organizers of this meeting for inviting me. I think it's a pleasure to come among my own and to give back, to where I was nurtured and where I find myself even now. So it's a great honor and privilege. But to start with, I would like to say that this presentation is purely my thoughts. The views and the thoughts and the text that is expressed within it are purely mine, and I have no link with any organization or individuals or any group. So if you want to use the material in this presentation, I would kindly advise that you speak to your doctor about it and then get the right information that is appropriate for your circumstance. I also haven't got any personal interest in most of the things that I will talk about by way of the appliances or medications. I have nothing to declare. So yeah, I am going to try to bring up my screen as I've been told. Now let's see. Can you all see my screen at all?
Yes.
Okay, all right. Yeah. Okay, so prostate enlargement and cancer is the topic for this afternoon. I think that to start with, there seemed to be a controversy within the topic itself, because when you talk about prostate enlargement, it involves a whole host of conditions that would make the prostate big. And I would say that prostate cancer is part of that spectrum, which can actually increase the size of the prostate. I think that to be a purist would have said that the topic should have been benign prostatic enlargement, but unfortunately the benign is being taken out. Benign prostatic enlargement is also called benign prostatic hypertrophy. So the names can be used interchangeably, but for functional reasons, I think we prefer to use benign prostatic hypertrophy, or sorry, hyperplasia, which actually gives you the functional understanding of what we are dealing with. So I will be using the terminologies interchangeably, but when I say either enlargement or hypertrophy or hyperplasia, I'm actually referring to the same thing. But to make things even easier for myself, I would call that a BPH, which is very straightforward and easy to use. Right. So I think these objectives have been shared on the platform already. Right. Okay. So these objectives have been shared on the platform already, that this webinar would increase our awareness of prostate diseases. Obviously, there are so many diseases of the prostate, but the three that come to mind quickly would be an infection or inflammation of the prostate, which is called prostatitis, and then we have the benign hyperplasia of the prostate, as well as prostate cancer. But there could be other conditions affecting the prostate. But this evening we'll be dealing with just two aspects of it, which is the BPH and then the prostate cancer. And obviously, because we talk about prostate cancer, we want to find out what the risk factors are for this condition. What actually makes an individual vulnerable for having this illness. And then we also look at the key factors to consider before asking for a screening. Because there has been a whole lot of confusion and controversies regarding prostate screening. And the public are confused, the medical establishment is also confused, and we seem to be working along anyway. So we want to look at some of those factors, why prostate screening is not, given to everybody, and why is it that even though we talk about prostate as being a leading cause of death among men, and yet we are not screening for it. And then we'll look at the management strategies for the BPH. So hopefully one of the objectives will be to learn how the BPH and prostate cancer are treated. I have outlined this. We look at some of the anatomy and the physiology, what the prostate is, where it's located, its function, and then we can come down to those disease elements that I've spoken about. That's benign prostatic hyperplasia, BPH for short, what it is, the symptoms, investigations, and the treatments that should go along with it, and what are the possible complications that BPH will come along with. And to finish off with that, we look at prostate cancer and look at its distribution, which people actually contract prostate cancer, what are the risk factors, the symptoms, the screening, which has been very confusing, and then test, treatment, and complications of CA prostate. Right, so to start with, I'll be using my mouse to hover over the picture. This is a longitudinal section. So assuming you've been split right in the middle, so you could see one half of your body. And so we're actually looking at the pelvis. So we've got a pelvic bone somewhere there, and then we've got a rectum, which is over here. This is the bladder. This is where the prostate is located. And then we've got the shaft of the penis, which is there, which ends at the glans penis. And we've got a testis all around here. So if you look at the anatomy, the prostate is actually sitting right under the bladder, and it's allowing the bladder to sit on top of it. And then it actually tapers downwards. It's more like a truncated cone, tapering downwards more towards the shaft of the penis. And it's located right in front of the rectum. So when sperms are produced in the testes, they would move from here into a storage, which is called the epididymis. And then they would move along this tube, which is called the vas deferens, all the way to join over here. That little pocket over there is called the seminal vesicle. This seminal vesicle actually contributes fluid, to the sperm, with its little fluid that is coming out from the vas deferens to form what we call an ejaculatory duct. And this would join the urethra to come out, through the penis. So when there is ejaculation, you're going to have the prostate contract, to emit all the fluid that is coming from both the vas deferens, the seminal vesicle, and then the prostate itself also contributes some fluid to that, and then it comes out. Obviously, the urethra is also a channel for the urine. Obviously, they operate at different times. So this is just a visual information for the prostate. Just as I said, it is located below the bladder and also in front of the rectum. It is shaped like a walnut, but for us, from where we come from, I would say that the substance that I would liken it to be the chestnut, which I'm sure most of us are familiar with. It's quite a very small piece of gland, but so important. The prostate itself is, enclosed by other connective tissues. The lining in the abdomen goes right down into the pelvis and then covers, the prostate. I've said that the prostate contributes fluid, about 30% of fluid to the semen. And not only does it contribute fluid, it produces what we call a PSA. The PSA is prostate-specific antigen, which is a protein. So this protein is secreted or passed into, or to join the fluid coming from the seminal vesicles and the vas deferens. And this actually nourishes the sperm. So when there's an ejaculation, which actually throws out the sperm into the vagina, you want the PSA to be these protein substances to give some sort of nutrients to the sperm. Not only does it provide nutrition, but it also reduces the acidity in the vagina. Without that, the sperms will not survive. And the third point that the fluid from the PSA from the prostate does is that it also liquefies, the fluid that coming from the vas deferens and the seminal vesicles, so that it will allow the the sperms, to swim upstream into the cervix and then wherever it's supposed to go. So PSA is quite important. At the same time, as I've said, the PSA is also secreted into the blood. So you can actually measure the level of the PSA in the blood. And that tells you about the activity of the prostate. I think we will talk about PSA later, but for now, I'll leave it at that. The prostate growth is influenced by testosterone, and the testosterone is coming from two places. One is from the testis, and then there's another area above the kidney. It's called an adrenal gland, and that produces also testosterone as well. But majority of the testosterone is from the testis, and that influences the growth of the prostate. I'm sorry that I have to do, back and forth because most of my lectures are based on a few pictures, really. So I hope you don't mind. Okay, so let me go forward. Yeah, so for clinical purposes, the prostate is divided into zones, and this is very, very important. Sorry. Yeah. So we have a transitional zone which actually surrounds the urethra, just at the neck of the bladder. So the bladder is sitting up there, and then you've got a urethra. So this transitional zone, is well around the urethra. Any enlargement, any increase in size of the transitional zone is going to constrict the urethra and make it difficult, to pass urine. I think this is so important because BPH, or benign prostatic hyperplasia, is purely to do with here, the transitional zone. It can affect any part, but majority, 95%, of BPH is more within the transitional zone. And then we've got the central zone. The central zone is actually the place where most of the vas deferens and then the seminal vesicles meet and join up into the urethra. And then we've got the peripheral zone. There's not much to talk about the central zone, but the peripheral zone is very, very important as well, because most prostate cancers develop within the peripheral zone. So it's like we've got two disease entities. One is in the middle, which is non-cancerous, and then you've got the other one, which is on the periphery, which can be cancerous. So actually, from the word go, you realize that if there should be any problem within the transitional zone, you are more likely to have the effect quickly compared to if there were to be a swelling, in the peripheral zone. That is a bit far away from the urethra, so that will take a bit of time. But having said that, you don't always have to have an enlarged transitional zone to have an obstruction in the urethra. You could have a transitional zone that is kinked because of its morphology, and that can compress on the urethra and cause you problems in terms of passing urine. So this is very important, and all the surgeries based on, if you've got BPH, the surgeon's intention is to make sure that there's a bit of relief, around the urethra within the transitional zone. If we are talking about cancer, we are talking more about the peripheral zone, which is accessible through the rectum. Going back to that, so I'm talking about the peripheral zone, which is outside. So you can see that you've got peripheral zone that is over here, and you've got some also at the front. If you're doing an examination to feel the prostate, you are more likely to feel the peripheral zone at the back. At the front, it's going to be very, very difficult to access. So if there should be any pathology in there, unfortunately, the hand is not going to feel it. But we'll talk about these things. Because we've got a picture on, I thought I'd better say this in time before lose the plot. Okay. Now, evolution of prostate gland. I've already said that the prostate grows in response to testosterone. So when there's a spurt growth, during puberty, we produce more testosterone. We feel we are progressing more towards maturity. And so testosterone would help us, to look more manly. The voice breaks. We have the facial hair. Then obviously our muscles also build up as men. So when there's that production of testosterone, obviously that is going to impact on the prostate, because it's actually going to feed the prostate. So from puberty, the prostate starts, getting bigger. It's growing, and that is normal. And this will grow to an adult size of about 20 to 30 grams, or if you want to measure it in volume, maybe 20 to 30 mils. But this would happen up to this size will be up to between age 30 and 45. Once you get to that stage, you expect that, wow, testosterone has built up to its climax, and therefore the prostate should be at the bigger size, at that stage. Unfortunately, it doesn't work out like that, because testosterone is like a parabola. It goes up and then it comes down. And so when it's coming down, you expect that there'll be a shrinkage, or perhaps keep the status quo of the prostate at that level, but it doesn't. Rather, the prostate keeps increasing. Why that is very puzzling. Do you know why the prostate should keep, our bones crumble as we grow older. Our skin might be wrinkled, but as for the prostate, it's in its elements. It keeps growing and growing. Others have postulated that perhaps the prostate itself is able to generate its own testosterone for its growth. How that happens is being investigated, because it's also important that even people who are being treated for prostate cancer, they try to reduce the level of testosterone in the blood by various treatments, and yet it gets to the point where it doesn't respond, and then it keeps coming back or growing without responding to the treatment. So there must be something inherent or perhaps adapted within the prostate that gives rise to that. So this is very important. Again, others have postulated that perhaps there is an imbalance between cell growth and cell death. For all of us, skin, we shed off skin, we replace them. So the body has got that programmed cell death, that when the cells are dysfunctional or of no use, or if there's any defect with the cells, then we have to shed them. But it looks like in the prostate, the rate at which it's shedding those cells does not complement the growth of it. But you're having more growth than cell death, which in medicine is called apoptosis. So not surprising, 50% of men at 50 years will have an enlarged prostate. And I'm saying an enlarged prostate. I'm not talking about the signs, the effect of the prostate. So when you actually examine, this is not possible, but most of this information has been gleaned from, autopsies, where they found out that, most men who have died have got enlarged prostate, but then they had no symptoms. So as we get older, majority of us, unfortunately, are going to have enlarged prostate, and more so when longevity is now on the rise. I think a lot of us are going to have this, and not only the BPH, but prostate cancer. So this is the evolution of prostate gland. Now, let's come down to one of our disease entities to talk about, and this is the benign prostatic hyperplasia. I think I've said already that within within the prostate, the cells are growing. So you're multiplying, you're having increase in cells in the prostate under the influence of testosterone. But this is more of a controlled growth. It's not non-cancerous. Usually we talk about cancer growth when you have abnormal, haphazard, uncontrolled growth with an element of, traveling into or growing into other tissues. That makes it cancerous. But benign prostatic hyperplasia does not invade other tissues. In actual fact, when it gets bigger, as per the diagram that I showed you earlier on, it would exert its effect on the surrounding tissues by pressure. So benign prostatic hyperplasia is non-cancerous growth of the normal prostate cells. And within that, you have smooth muscle cells and then connective tissue. So this is also very, very important. So we've talked about the prostatic cells themselves, that they are increasing. At the same time, we also have smooth muscle cells, which are also increasing. So these cells are quite elastic, as you imagine. So if they should increase in size, they are going to exert, that pressure on the urethra because they are encircling it. So you imagine that you've got a tube and then you've got a band around it, which is growing and getting bigger. Obviously, to constrict it with time. Right, let me make sure that I'm going in the right direction. Yeah. Okay, so with benign prostatic hyperplasia, you can see all the changes that are happening. This is a normal prostate. This is a normal urethra. It's quite open, so you can have urine, which will come through from the kidney. So you've got a kidney sitting somewhere there. I think you have to imagine where the kidneys are. And then they open into the bladder, and then the urine comes out. So this is okay. That's fine. Keep watch on this, the muscle of the prostate. Keep watch of the changes within the lining, and then keep watch of the prostate. So now the prostate is enlarged. Obviously, it has blocked the urethra over here. The lumen is so narrow. That is one. So enlargement, and this enlargement is pushing into the bladder. And not only that, once you got a resistance or high resistance over here within the urethra, you are going to have the bladder to do more work to squeeze, the urine to go through the urethra. And eventually you have the muscle of the bladder also getting bigger. Obviously, you say a local mature process. So it gets bigger because it's exercising. The danger is that as it gets bigger and does more work, just like a heart that is pumping against so much pressure, it can actually get weaker. And when it's weak, the pressure inside the bladder is going to look for areas of low resistance. And that can cause pockets to develop within the bladder. So you're going to get like a ballooning of certain areas of the bladder. And that can lead to infections. You can also have urine actually sitting in there, and the secretions of the salts within the urine can precipitate, and that can lead to bladder stones. I'm not talking about kidney stones because that will be high up, but I'm talking about bladder stones. And if you've got a stone that is dislodged from any of the pockets, that can also obstruct the urethra and compound your problem. It can also lead to infections because you are unable, to empty the bladder. So what are the effects? Sorry, I'll come back to the effects in a second, but let's talk a little bit about facts about the BPH. So BPH actually emerges when we are in our 50s, as I've said earlier on. So we're talking about people in their 50s who are more likely to have enlarged prostate. So 30 to 45, you hit the maximum and hoping that, you stay there. Unfortunately, life is not So it keeps progressing. And so it gets bigger. And so you have 80% of people in their 9th decade, having an enlarged prostate. Because as we grow older, the prostate gets bigger. There have been observational studies in the US to suggest that Black men have increased transitional zone. And that is what I pointed out earlier on, which is the zone just around the urethra. And so if the size is increased, you're more likely to have more problems. So they have increased transitional zone and total volume of prostate than white men. But this is also very controversial because there are some studies which point out that perhaps up to the age of just before 60, that might be the case, but after that, might be less. And the same thing applies to testosterone level as well. So there were people who were being assessed for prostate cancer. So they took their blood to check their levels of testosterone. Those below the 60, especially the Black folks, seem to have a slightly higher level of testosterone. And then after 60, they equalized, they became the same. So there wasn't much difference. If you've got a father or a brother who has prostate enlargement or BPH, you are 4 to 6 times at risk of having the same thing. And for those people, they tend to have, bigger prostate earlier in life, and then also have the symptoms as well. So the volume of prostate is increased for those people. Obesity has been shown to be, there's an association between BPH and obesity. Why that is, we don't know. But then it's postulated that perhaps there are some growth factors that evolve when we are big, and that also influences the size of the prostate. I'm not talking about, the pressures, that we exert in the abdomen, which also exerts on the bladder to work out the whole process. Lately, there has been an association between BPH and erectile dysfunction. So one of the guideline groups in the United Kingdom, which is called, we call by an acronym NICE. I'll delve into that as we go along. They suggest that if you have a man who presents with erectile dysfunction, it is always good. It's mandatory actually to assess the prostate to make sure that that's not contributing to that. So going back to the effect of the BPH, the effects have been divided into 2 parts. So one part is to do with the filling of urine into the bladder itself. Is the bladder able to contain that urine? And then the other one is when you are passing the urine out of the bladder. So that's avoiding problems. I think it's no big science to actually predict what would happen if there's a prostate enlargement. It's much easier with avoiding problems because you're going to have difficulty to pass urine, and the flow is going to be poor as well. In fact, I saw a picture of a presenter who had actually taken a picture of himself and showed how the trajectory of his urine, at age 30 compares to when he was at 50. So at 30, it seemed like the trajectory is more like a parabola, goes up and then comes down. Nice. And then at 50, it feels as if the whole thing is falling on his feet. So that arch there is much acute, it goes right down towards the feet. So anyway, so people with effects, so I'm talking about effect. I'm not talking about people who have got a enlarged prostate and yet haven't got any symptoms. People who have symptoms are going to have difficulty to pass urine, and the urinary stream is going to be poor. When they actually go to the bathroom, they would have to wait for some few seconds or minutes before the urine comes out. So there's a delay in initiating because you have to build much pressure to open up, the tube to let the urine come out. And they have to also strain as well. because the lumen is narrow and you have to do more work to do that. And they feel as though they haven't actually emptied the bladder completely. And so they want to always go back, to the loo to pass another volume of urine. Unfortunately for those people, because of the work that is being done on the prostate has got a rich array of blood vessels, and some of them can rupture to cause bleeding. Now going back to the point A, the storage problems. Now if there's an obstruction, the bladder is also going to reconfigure itself, that I'm having too much pressure over here. You need to get out. You need to get out. So when you feel like going to the toilet, to pass urine, there's no time to waste. The bladder is contracting so much that it's actually urging you. You've got to go now. You have no time to waste. And actually, some people could have incontinence of urine by that, because they can't actually go, they can't be quick enough to get to the bathroom. At night, you are more likely to be waking up because the bladder fills up, and then because the bladder is irritated, the pressure that's built up, it will actually tell you that you've got to get up. So you've got an individual who is passing urine a lot at night. You've got to think about prostate, depending on your circumstance. There are other conditions that can give rise to that. Diabetes could be one. High levels of calcium could be one. Kidney malfunction or impairment could be one as well. So there are a variety of infections. All these things could cause that, but I'm talking specifically about prostate, that this is one of the symptoms. It can also lead to wet in the bed, because obviously the control is not there. And then after passing urine, you get some trickling, so that's called a dribbling, after passing urine. So we've got the storage problems, which is more to do with the effect of the pressure, the outlet flow that has been restricted. That effect on the bladder makes you want to pass urine all the time, or at night, make you want to go to the toilet to pass urine. And then you've got the effect of the pressure, that narrowing itself makes it more difficult for you to pass urine. Right. So if you've got, I think I've spoken about some of these complications about enlarged prostate. If the prostate is enlarged, there's a back pressure that is transmitted through the bladder into the ureters. Unfortunately, I haven't drawn the ureter. So for people who don't know ureters, that's a tube from connecting the kidney to the bladder. So you have to imagine that you've got a urine that is backfilling into the ureters, So that is hydroureter. And then if the hydroureter also affects the kidney, that pressure that is exerted on the kidney can lead to the small channels within the kidney also to get bigger, and that is called hydronephrosis. So nephrosis is kidney, hydro, so you've got more water there. So hydroureters and hydronephrosis, and that hydronephrosis can lead to kidney impairment. There can be bleeding. I've spoken about that already, but if there's bleeding, you don't always think that it's the prostate. You've got to think about other things as well. The bladder, you've got a problem with the bladder, that can give you blood. If there's a kidney stone or a bladder stone, just imagine you've got that hard stone that is irritating the lining. That can also give you blood. I've talked about the pockets that can be formed in the bladder because the pressure is transferred to the low resistance areas of the bladder to form outpouching or pockets, and that can lead to stones and then infection. Unfortunately, if the outlet is blocked, then there's going to be a backflow of sperm into the bladder. So after ejaculation or during orgasm, you realize that nothing comes out, it's dry. And then you go to the bathroom, you pass urine, and you find, something else coming out. All because the pressure, within the ureter is so much that the prostate is blocking, that passage. And so there's a backflow of the sperm into the bladder. The worst scenario is having acute retention of urine. That is very, very painful. I once had one of my patients who unfortunately had such condition. And then when he came back to the surgery, he said, well, I'm not sure whether this pain is compared to childbirth, even though I've never had, I've never delivered a child before. But it was so severe, he couldn't fathom or think of any pain that could be likened to that. So he thought that perhaps for him, that was more than childbirth. So acute retention of urine, and that is very, very painful. And unfortunately, it does happen in the night because you'll be sleeping, the bladder is filling up, there's no control, and because the bladder outlet is blocked, that gives you this very, very severe pain. I've talked about infections. If the prostate is enlarged, that can lead to recurrent urinary infections. I've spoken about the other two, urinary incontinence, erectile dysfunction. So shall we? So what next? Once the prostate is enlarged, what do? Perhaps you have to go and see the doctor. The doctor says, okay, I think perhaps we'd have to assess you and find out what is going on here. And mind you, don't go and meet that person who points his large fingers and tells you that, well, hello, I'm Dr. Grossfinger. I'll be your urologist. I'm sure that might scare the hell out of you. Say, well, give me a minute, I shall be back. So for the assessment, the doctor would have to examine, obviously for the assessment, I think I'm holding it down to the BPH, but for every individual, you're going to do a complete medical history to find out whether they've got problems, heart problems, or kidney problems, or they have any other comorbidity or medical illnesses. You want to take the history, which I've talked about, in my previous slide. Here, this is more to do with the physical assessment that you make. So the first one is digital. I indicated that in my first picture, that it's easier to pass finger through the back passage to have a feel of the prostate. But again, that can be equivocal. If the swelling in itself is right in the middle and hasn't actually pushed back into the peripheral zone, you are unlikely to feel it, and probably might give you a different impression. And you also need an experienced hand, to do the rectal examination. When you do the rectal examination, I know it's very embarrassing, and most people would not like that, but it's also very important. Obviously, if you're not happy with it, you don't have to agree to that. The doctor will seek your consent to do that. They can do, different stuff. But it is very helpful because when you do the digital rectal examination, you can feel for the consistency of the prostate. If it is BPH, it feels rubbery. If it's hard, that should tell you that more likely to be a cancer. And then you feel whether the structures in front of or in this case, behind the prostate can move. If they are attached, to those structures, that tells you that there has been some infiltration. The prostate also has got a groove right in the middle of it, the median circles. If it is cancer, it gets filled up. But if it is not, you can actually feel the groove in there. But this is just a sideshow. The most important thing is that the doctor does a digital rectal examination to estimate the size of the prostate, the consistency of it. And if perhaps you have an infection in the prostate, prostatitis, touching the prostate can be very painful. So there are quite a lot of things that you can actually pick up, by doing the digital rectal examination. The doctor might also ask for a test. So these are people who are having symptoms, who have been to the GP and said, well, I'm having some trouble passing urine. So then the GP might request for a PSA if it is necessary. And then check the kidney function, because kidney function can also give you urinary problems. Calcium, I've said that already, diabetes, and that. And then obviously take some urine specimen to check for infections in the urine. What your doctor could also do is that they can actually do a 3-day urinary frequency volume chart, and that is give you a very simple basic chart and time, how much you drink and how much you are passing out. And you can actually work out, to find out how much that person is passing urine at night, because that chart will tell you that this person is waking up a lot at night, to pass urine. So that tells you that there's nocturia, as I said earlier. So that's why nocturia, frequent passage of urine at night. Yeah. And then it can also tell you about the volume of urine that this person is also producing. These two that I've actually highlighted are tests done more in the hospital rather than at the doctor's surgery. Uroflowmetry is to assess how fast you are able to pass urine. Because of the constriction, they will actually make you pass urine into a system, and that system will be working out the speed of the urine. So that will tell you that if your speed is so slow, obviously that's an indication that there's an obstruction in there. And all these things would also help the doctor to choose what sort of treatment to offer you. You can have ultrasound scan, which can also look at how much urine is left in the bladder after you've tried to empty it. So if you are leaving more than 100 mils of urine in the bladder, that's abnormal. If you're passing urine, we expect that everything will come out. But for some people, and of course, if you've got a BPH, you are going to have residual urine in the bladder. So the other thing that your doctor can do is also, there's this International Prostate Symptom Score. It is just a way of calibrating or finding out from you the impact of your urinary problem on your life. And actually, it's not to make a diagnosis, but it's also to tell us how this is impacting your life. I've got about 2 slides which are going to come up, and they are very busy. I'm sure you'll catch up with me on that one. Okay, so this is the international, the IPSS, and the IPSS is asking you that in the past 1 month, how much have you been bothered by having an incomplete emptying of your bladder? So you might say, well, not at all, it doesn't affect me. But maybe out of 5 instances or episodes of passing urine, I might have 1 of them that I feel that I haven't cleared my bladder completely. So it goes on, to 5. And then again, how often are you passing urine over the last past month? So this question is the same, but then it tells you about something different. Intermittency means that as you pass the urine, it stops and it starts again. So the stop-start will give him an idea that perhaps there must be obstruction. The urgency is that urge to go and pass urine. You don't have time. When you have to go, you have to go. There's no chance of wasting time. Woe betide you if you have caffeine, tea, coffee, or have alcohol. These are diuretics. They help you. They actually urge you to make more urine and pass urine. So woe betide you. You have this problem. You go out into town and dear me, if you don't know where the toilet is, you're going to be in trouble. So people with urgency, as soon as they go into town, the first thing they look out for, the toilet. Where is the toilet? Because they know that if they run into emergency, they have to know where to go immediately. And the same thing applies to women, but of course, under a different disease entity of urgency. So it just will ask you about weak stream, straining, and So you score them. So at the end, if you add up your score, if your score is between 1 to 7, that means that, you know, there's somebody who is not bothered so much about his condition. So you don't need to do, all you have to do is to watch and wait. Of course, if you've got somebody who has got a score between 8 to 19, that's a moderate effect. So those ones, you will be thinking that perhaps you've got to do something as a doctor, or they need relief, some form of relief. If it's very, very, so the moderate ones, you'll probably be thinking of medication. And then you've got the severe ones. Again, you are going to toggle and say whether you'll be able to use medication for those severe ones, or you have to go for surgery. Obviously, surgery is going to be the last because it's got quite a lot of problems. And I think also the bonus question that if you were to spend the rest of your life with your urinary condition, just the way it is now, how would you feel about that? So again, you have to score. This has got nothing to do with the previous assessment, but it also gives you, it tells you about the quality of life of this individual, whether they are quite happy with what they've got or they are really, really bothered, you know, by that. So when all these assessments have been made and it's been confirmed that you've got an enlarged prostate, and just by the score that I've just talked about, if your score is so low that you are not actually bothered by the symptoms, then you don't need any treatment. I think basically what you need to do is to, you know, have lifestyle change, and that would involve, you know, cutting down on caffeine, those stimulants, those things that would, you know, urge you to go and pass urine, and then you cut down on fluid at night. And you got to exercise, obviously, to lose weight, to reduce the impact, you know, of the enlarged prostate. Now, if that doesn't work, or you are within the intermediate category, then I think we'd have to give you some treatment. And at the moment, there are two important treatments that we are using. In describing the pathology or the abnormality within the prostate, I said that we do have muscle fibers, smooth muscle fibers within the prostate. And these muscle fibers have got receptors, you know, on them, and they react to, you know, chemical substances to contract. So if we are able to block these receptors by what we call the alpha adrenergic blockers. Okay, right. So if we're able to block those receptors, then obviously the muscles will be more relaxed and then relieve you of the pressure or that constricting effect around the urethra, relieve you of that to allow the urine, you know, to come through. Alpha adrenergic blockers also do have side effects because these would work on blood pressures as well, and that can make your blood pressure, you know, low and give you a bit of dizziness. So they come with a price, even though they work quite well. So that is one class of medication. The other class of medication is the 5-alpha reductase inhibitors. Again, going back to the pathology, I have said that you need testosterone to, you know, influence the growth of prostate. Now, the testosterone by itself is not acting on the prostate cells. It's also changed into one of its products or metabolites, and that is called dihydrotestosterone. So dihydrotestosterone is so important. That is what is actually influencing the growth within the prostate. So what we need to do is to oppose that effect, that conversion, because the testosterone is going to be converted to dihydrotestosterone, and you need an enzyme, or as it were, a catalyst, you know, to change the testosterone to dihydrotestosterone. So if you can have a medication that can affect, that enzyme that is changing the testosterone to dihydrotestosterone, then you are going to reduce or limit the change within the prostate. So alpha adrenergic blockers, I have to go back, alpha adrenergic blockers would work within a couple of weeks. It takes about 2 weeks to have some effect. 3 months or 6 weeks, you should be up and running. But if you come to the 5 alpha reductase inhibitors, they work quite slowly because they would have to go into the nucleus to, affect or slow down the growth of the prostate. And so that takes longer. So you're actually going to experience its maximum effect maybe somewhere around 3 months, up to 6 months before you see the effect. Sometimes they can combine, the alpha adrenergic blockers and then the alpha reductase inhibitors. Depending on the size. If you've got a very bulky prostate and your PSA level is very high, let's not forget that the testosterone is affecting the prostate to get bigger, to lay more cells, and then also help those cells to produce more PSA. So if your PSA is high with BPH, perhaps more than 1.4 nanograms per liter, that would be an indication that perhaps this is somebody who can progress. The disease progression can, be there, and therefore you want to stop that from happening. So we give you the 5 alpha reductase to stop that growth, and then the alpha adrenergic blockers will be relaxing the smooth muscles within the prostate. Recently, there's one of these medications which are used for erectile dysfunction. Even though it's not been licensed to use in the UK, it's being used elsewhere. You've heard about Viagra, you've heard about the other bits. This is one of those medications within that class, tadalafil. And what tadalafil does is that it enhances what we call nitric oxide. This nitric oxide actually relaxes smooth muscles. If ever any of you have heard about nitrates, nitrates are used for people who have either ischemia or heart attack, and actually they give them as a pump, or it can come as a tablet as well, and that helps in relaxing, the smooth muscles within the heart, to relax, to allow blood to flow into it. So that's what tadalafil does. It relaxes the smooth muscles. So if they give it to you every day, you are more likely to have that effect. But as of now, this is under investigation in the UK. So once the medications are being utilized, if there should be failure of the medication, then the last point of call is going to be surgery. Before I go to the surgery, I'll go to the next slide, which actually encapsulates all the things that I've talked about, the medication. So if the prostate size is big and is blocking, the bladder outlet, you are going to need these medications that relax, the smooth muscles to allow the urine to come through. Unfortunately, for some people, they are going to have irritable bladder because of the pressure that's been going on for a long time. There's rhythmic contraction is increased within the bladder, and so it makes you want to go. If that is so troublesome, there are other set of medications that can be given in conjunction with these ones, to try and stop that. Obviously, as I said, if your prostate is also enlarged and your PSA is high, then the alpha reductase inhibitors, an example, what I've written down here, which can also be used for that. Now, going back to the surgery, the gold standard of when I was in Ghana, I never came across transurethral prostatectomy because this is more like using a keyhole as it were, pass it through the urethra and then try and scrape that transitional zone that I showed you. I think I should have something here. So this is a diagram, a picture that I've picked from the internet to make things easy for myself. So you can see that here it's chock-a-blocked over here. So you pass the instruments through, it goes in there, and you try and scrape what's in the middle, away. And so eventually that's what you're going to get to allow the urine to flow out nicely. And don't forget that as you create this hole, you make the whole place weak, and that can lead to incontinence. So you have one problem solved, and then you have another problem also develop. But certainly with time, you expect that the prostate will correct itself and narrow the enlargement a little bit. And for some people, the incontinence will go away. For that other people too, it might be bothersome and go on for a little while. So that's the transurethral resection of the prostate, and that's the scraping away. They use a hot metal, to scrape away that inner bit of the prostate to enlarge that space so that you can have free passage of urine. In some cases, this is also something that is being pioneered. It's a clip. It's just like an implant. So this is the enlarged prostate with the occlusion. You pass through the instrument, and then you deliver implants, to keep it apart, so that you open the prostate. So this one doesn't really require a lot of preparation, unlike the TURP, which is a transurethral resection of the prostate. So this can also be used for smaller prostates, because if it's so big, I don't think you can use this. So these are for smaller prostate. So there are new technologies that are also coming up. They are using laser for treatment, and that will burn off, the inner core of what I showed you, the transitional zone. They use all forms, to try and clear that, to increase the free flow of urine through the urethra. So why would an individual have surgery for prostatectomy? I think when I use prostatectomy, please be careful that I'm not saying that prostatectomy means that you are removing the prostate, but it's a partial prostatectomy. You are removing part of it, but that's how we call it. So one would have surgery when there's a kidney problem because of the pressure that has been exerted by the prostate tissue or gland on the bladder, and consequently affecting the function of the kidney. Or if there's growth, a lot of bleeding, which is uncontrolled, that's not good for you. If there's recurrent urinary tract infection, bladder stones, or just as I've said, the last refer to lower urinary tract symptoms, and that is what I spoke about: passing urine often, having the urge, passing urine a lot at night, poor stream. Those are the LUTs, lower urinary tract symptoms. So if these are refractory or not responding to the medical treatment, then that's what you do. Right. I think I've just touched a little bit on the complication of surgery because the space is open. You are more likely to have incontinence of urine, and then that can also lead to frequent urinary infections. Again, even though the passage has been open for some reason, there can be a backflow of sperm into the bladder because now the place is wide enough, the prostate contracts, and then it can be backtrack of the sperm into the bladder. Again, this can lead to erectile dysfunction. For some people, it can lead to a lot of emotional changes, especially just imagine you have incontinence of urine, or you have a lot of recurrent urinary infection, or perhaps you have erectile dysfunction. I think that can affect you emotionally. And so I think I hope I'm doing well with time. I'm going to rush through the prostate cancer because I think I'm going a bit slow. Okay. So prostate cancer. I've talked about BPH, which is entirely different. And when you have BPH, there's no association with prostate cancer. The pathologies are different. The chances of you going to prostate cancer is very, very minimal. But having said that, you could have cancer and BPH coexisting. Okay. So prostate cancer in the UK is the commonest cancer in men. It does affect about 47,500 cases are picked up each year. And so I don't know the size of Chelsea football stadium, but maybe if it is up to that level, you're talking about almost 50,000 people filling up. But cancer, prostate cancer UK has done a very nice analogy, you know, with football stadium, and I think they call it checking the score, something like that. And so it gives you all some of the statistics around how many people fill a football stadium and the like. So BPH is for people in their 50s, but prostate cancer is also for people in their 60s. But it doesn't mean that it starts at 60. It starts before then, but then it will come to the climax, you know, when you are at 60. So 50% of men at 50 probably have got prostate cancer without any symptoms. They don't know about it, you know, and you know they are not bothered because nothing is happening. But with time, if you know it progresses, it can catch up with you with symptoms. So 50% at 50, 60 at 60, and as you go up the ladder, you know, it gets even worse. But it's not everybody who has got prostate cancer who has got an effect. Majority of people do not have effect of the prostate cancer. So most of them are diagnosed, 99% of men diagnosed are age 50 years or over. It has been claimed that perhaps even prostate cancer starts from age 30 and then it builds up, which we don't know. But at autopsy, they do find a lot of prostate cancers which have been present in people without any symptom. Unfortunately, prostate cancer is commoner in the developed countries, but then there's a bit of an argument. You would have thought that, you know, prostate cancer should also be in the developing countries, especially in the Black communities. Unfortunately, the registries there are not up to scratch, so we are not able to get the right statistics, which tells us that, yeah, prostate cancer is quite high over there. However, it is known that prostate cancer is common in Black men, perhaps because of the different lifestyle that we take, you know, in the Western countries. Because the facility, the screening processes are here, the tests are here, you know, unlike, you know, developed countries, we're able to do more tests and then pick up prostate cancer. Prostate cancer is actually the commonest cause of death in men in the UK. The exact cause of prostate cancer is not known, but in part is attributed to testosterone, because the testosterone, even though it's now producing, you know, or making the prostate enlarge, it can also lead to exaggerated or overexuberance of growth, and that can lead to abnormalities within the prostate. So what are the risk factors for prostate cancer? I have already alluded to the fact that it comes with age. As we grow older, we are more prone to having prostate cancer. So if you take the typical Mmarima Mma society, some of us, you know, are going to have prostate problems, either by BPH or prostate cancer, because as we grow older, all these things are bigger, and that can lead to its symptoms. As I've said earlier, the risk in the UK at the moment is 1 out of 8. So if you took 8 men, I mean adult men, one of them, would have a lifetime risk of having an increased prostate cancer. But even it's worse when it comes to Black people, that 1 out of 4, of us would have prostate cancer. And when it happens at a younger age, and the grade, the severity of the cancer is also high. Unfortunately, the outcome is poor. So we tend to have earlier prostate cancers, and then we have poorer outcomes. The sad news is that 90% of Black men are not aware of this. Why that is also very puzzling. Either we don't have the information, or maybe we are inhibited from discussing these issues adequately, or we are not informed through the right channels. I think that we left to the audience to come up with some ideas, but certainly most Black men are not aware of this. Now, the other risk factor is that if you've got a family history of prostate cancer, then your chances of having one is also increased. So you're a Black man, you've got a parent, a father, or a brother. That's a close associate, the first degree relations. If they have prostate cancer, then obviously your risk also increases. It has also been found out that women who have breast cancer, who have a gene called breast cancer gene 1 or 2, their brothers are also more likely to have increased risk of having prostate cancer. It is to a lesser extent with the breast cancer gene 1, which we call BRCA1, but more so with the BRCA2, breast cancer gene 2. That is more associated with prostate cancer in the relations of those women. So the risk factors are quite important. Know that as a Black person, you've got about 2 to 3 times increased risk compared to white men. And actually, the gradation is from Black to Caucasian and then to the Asian. I think the rates among the Asians are quite low. So prostate cancer, there's abnormal growth of cells in the prostate, also in response to testosterone. So this testosterone is playing up in BPH, is also playing up in prostate cancer. And the offending metabolite or product of the testosterone is the dihydrotestosterone. So if you have anything at all, if we can reduce that, that would be very, very helpful. But it's not as simple as that, because some people who try to prevent, there was a study to find out if the finasteride that I spoke about, or the 5-alpha reductase inhibitors that I spoke about earlier on, if they gave it to individuals just to find out whether they could reduce their risk of having prostate cancer. Yes, it did. It reduced the chances of having prostate cancer. But guess what happened? When they had prostate cancer, they had a worse form of it. So we're not using this mode, to try and reduce it, because if you do have prostate cancer, you have the worst form of it. So testosterone is converted to dihydrotestosterone, and this causes the damage. And I've said earlier on that most of the prostate defect is found more in the peripheral zone. So going back to that, right up there. Yeah. So you've got a prostate cancer sitting somewhere here. That's not going to really give you any symptom, because it's going to take a while, for it to increase in size to press on the urethra. So for those who have got prostate cancers that are patting on the urethra, that must be the worst form of prostate cancer, because it's been there for too long and it's actually grown bigger. Yeah. So the symptoms of prostate cancer depends on the stage, how advanced it is. And the majority of people, they don't have symptoms, unlike BPH. So BPH, you're more likely to have precipitated symptoms, but then in prostate cancer, it's quite delayed. So sorry, I have to go to where I left off. Okay, so the effect depends on how advanced it is. Usually there's no symptom, and if it is quite advanced, you are going to get those voiding and then the storage symptoms that I spoke about. The increased rate of passing urine at night, not able to hold urine, and then having poor urinary stream. However, prostate cancer, as I've said, these are abnormal cells that can migrate from one area to the other, either through the blood vessels or perhaps what we call lymphatic channels. So these are also vessels within the tissues that collect all the tissue fluid that are being pushed in the back into the lymph nodes and then into the main stream of the blood vessels. So prostate cancer can spread to the bone. Usually that's a common area. So if you've got any person, 50-year-old, 60-year-old, they come to you, they complain of, I've got this back pain. I don't know what it is, but it's really nagging me. I'm not suggesting that all back pains are due to prostate cancer. And more especially if you are black, then please prompt your doctor about it. That you probably have to be thinking about that. Depending on where the metastasis or the spread has been, that would dictate the sort of symptoms that you have. If it is the lungs, you're more likely to feel out of breath. If there's an infiltration into the bone marrow, that is going to lead to anemia, so you're not going to be able to produce the red blood cells that you need. And so they're going to feel breathless or tired on slight exertion. Depending on where it is, it might give you headache or seizure in the brain, or you might have the general symptoms, just like any other cancer, where you have poor appetite, loss of weight, and tiredness. Right. I think I have to really hurry up. I'm running so late. Right. Again, the assessment will be by digital rectal examination. I think I've been through all this. I'm not going to spend a lot of time over there. Your doctor would have to do a PSA to find out the level. So for each age group, there's a nomogram. So the doctor will compare, the level of your PSA to your age. And if it is that high, then they would have to take an action. Here in the UK, the National Institute of Clinical Excellence, I think I'm more used to that acronym but then they've added health and care excellence to it. The NICE guideline says that if your PSA is more than 3, then you have to be referred to the hospital for further assessment. You have MRI scans. These are specialized MRI scans, to check whether the prostate cancer is actually expanding into other tissues. And then from there, you get a biopsy, which should be done. And that would lead to combining the MRI scan and the biopsy would help us to stage the disease. If they think that you've got a prostate scan and prostate disease and you have a spread, they do a bone scan to find out whether the bones have been affected. I'm not going to spend much time. MRI and the radiology is going to determine whether what he's seen there is a very low risk or is moderate or is very high. Now, in the past, what the doctors did was that they actually did a PSA. If it was high, then they went straight to do a biopsy. The biopsy also has got its own problems because you're going to use an ultrasound scan and a needle to take tissue from the prostate. That can lead to bleeding, it can lead to infection, it can lead to blood in the urine. So, and it leads to a lot of difficulties for the patient. So what they've done is that now they've come up with this specialized MRI scan, which will actually determine whether you need to have a biopsy done or not. And that is that. This is all about the biopsy. You don't need to worry yourself about this. When the biopsy is done, the pathologist will grade the cells that are found in the. So they're actually looking at is comparing the cells to normal prostate cells, whether they are close, to normal prostate cells, or they are actually a deviation. There's a huge deviation, from that, and that is classified, and that is called a Gleason score. So Gleason score is very, very important. It tells you how bad the cells are, from the, again, this is about the scan. It tells you where the prostate cancer is, if it is within just a little bit of, well, if it's very small within a lobe or it's quite big. These are giving scores as well, and that is the staging, or whether they're actually about to erupt into other tissues. Once the cancer is determined, we categorize it into a low risk or intermediate risk or high risk. And all these things depend on the level of the PSA that has been done, the prostate biopsy, and then the clinical stage, which is from the MRI scan. So if your PSA is less than 10 and the Gleason score gives you less than 6, then the scan also puts you at T1 or T2A, then that means that you are at low risk. For those people, we can actually monitor them. We don't need to treat them, because we do know that prostate cancer is slow growing and most people will not have any effect, and therefore it's much better to follow them up. There are people who will be anxious about this. How can I live with prostate cancer? I really need to do something about that. So these are localized prostate cancers. The management is that, as I've said already, if the prostate cancer is localized, then perhaps you'll be put on what we call the active surveillance, which is what I've spoken about already. That you probably be given appointments to go to the doctor to do your PSAs, to do a distal rectal examination, perhaps in a year to have MRI scan, just to find out whether the prostate is progressing or not. The prostate cancer is progressing or not. For those who cannot live with it or who have higher risk, they might have the surgeries. And this surgeries means that you are removing the whole bulk of the prostate, unlike the BPH, where they take part of it. In this instance, they are removing the whole prostate. And that can lead you with severe consequences, because the prostate is not the place is going to be loose. You're going to have incontinence, ejaculation problems. That's going to lead to erectile dysfunction. It can also lead to recurrent infections, all the things that I spoke about concerning the partial removal of the prostate. Others might also have radiotherapy because they actually don't want to have the prostate removed. But that's an option that you could have. But all these things would have to be discussed, taking your peculiar situation into account. There are other new forms of treatment using ultrasound scan. Now, if the prostate is quite advanced, then obviously the surgery is not an option. So if it is localized and it hasn't actually broken its boundaries, gone beyond the capsule of the prostate, then you can have this radical prostatectomy. But once there's a spread, that becomes a limited option for you. So then you'll be more dependent on hormones and then chemotherapy and radiotherapy. Can I be screened for prostate? No, at the moment we don't have any screening protocol in the UK. We don't have population screening for prostate cancer. And I believe that in the whole world, there's no country which has come up with a population screening protocol. It's just because of some of these inconsistencies. One is that prostate is a very slow growing, the prostate cancer is a slow growing process. It's highly unlikely for some people to even have an effect. If you do population screening, you're going to pick a lot of people with high PSAs, and that's going to lead to intrusive investigations like the biopsy, which is going to lead to bleeding and infection, or perhaps they take the biopsy, they are not able to find any disease in it, and then you have to go for another one. Now they are getting better at these things because of the specialized MRI scans that they have, to be able to hone in on the lesions. And then you've got, if you have the very high PSA, you have all the investigation, perhaps you are more likely to have treatment as well, which has got its own attendant problem of the incontinence and the like. So before you have a prostate PSA test, you have to know the facts about prostate, that it increases as we grow. People with positive family history and black men are most at risk. The prostate is a big spectrum of disease. Majority of people might not have any problem with it, but certainly if you don't if you don't have the test, you are unlikely to know whether you've got a cancer or not, the worst form of it or not. And so you have to wait until you have symptoms, which by that point would have been too late. So the test is not adequate. PSA can be high if your prostate is large, if you've got prostate infection, or if you had any instrumentation, or if the doctor has put a finger in the back passage to examine the prostate. That can also increase the PSA. But that is quite transient. Actually, ejaculation can also increase the PSA as well. I've said serious complications to the treatment. Benefits of testing is early prostate cancer can be detected, and then effective treatment can be offered as well. It will allay the anxiety. My father had a prostate cancer, my brother has a prostate, do I have it as well? You know, if you have the test, at least if it's normal, that can allay your anxiety. But that's not the end of the story. If you took 100 people who have had normal PSA, 15 of them might have prostate cancer. So that tells you the difficulty with the PSA test. And of course, if you do the PSA test, your progeny, your children, might know where they stand. I've left this cancer.org. They have a lot of information that people can look at regarding PSA and tests. So in the UK, there's no population-wide screening program. They advise that men who are symptomatic should rather have the screening. Yes. If you are not symptomatic, you don't have any symptoms, then you have to have an informed choice. You have to know about the inconsistencies with the tests. Blood tests, the biopsy, the scan, all of them have got their weaknesses in there. So if you have the test, you have to know that you're actually going to go through this the route if there's an abnormality. And I think finally to say that prostate is unique to men. It enlarges with age in response to testosterone. Then it gives all the symptoms. The treatment is by surgery if medical treatment, as in BPH, is not effective. And then with prostate cancer, depending on the stage, you have either the active surveillance or you might have other treatments. There are links over there that I've left over there that you can actually access. So yeah, I'm done. Steve, I think
yes. Thank you so much, Dr. Kensah. I don't know why you've kept all this information from us until date, but we thank the organizers for putting up, introducing this subject to us. We're going to take some questions now. So anyone who has any questions, please shoot. Do we have any questions from the chat section at all? Yes, we do.
I do.
Okay. Right. Please mention your name. I can only see a number, and then start your question.
Hey, this is Dr. Paul from Georgia. Hi, Dr. Kensah. I have 3 questions. Can you hear me?
Yeah, I can hear you.
Yeah. Hey, how often do we have to go for prostate screening? And number 2, I hear people say increased sexual activities helps in reducing the prostate size. Is this true? And the last question is, this is more something like whether it's psychological or not. That is, sometimes you feel the urge to go pee, but then you can hold on to your pee for quite some time until you realize, oh, that's the restroom right there, and the pee is like you can't hold it anymore, it just starts to come out. Is this psychological?
Okay, thank you.
Dr. Paul.
Is it Paul?
Palm. Henry, your roommate.
Okay.
Yeah.
Right. So thank you for the question. I think I'll start from the bottom. So I think it's a good practice really to, when you feel like passing urine, to do it. Because the bladder has got nerves. And so when the bladder is actually stretched, this will be sent to the brain. And that tells you that something needs to come up.
Right.
The body is actually prompting you that it is time to do it. But of course, it all depends on the circumstance. Maybe you are sitting in a meeting, like I'm talking now, and I have to try and hold it, or perhaps the situation might not be so conducive for you to let it out. So you probably have to try and hold it. But generally, as a rule, it's much better to let the urine out, because I've just told you that you don't want the bladder to be overworking itself and then to be irritable with time. Yes. So if the bladder becomes irritable, then you find yourself always, even though you've done the right thing to hold it, now it's actually giving you a negative effect, that it becomes so irritable that once you have it, you've got to go. When you got to go, you got to go. Yeah. So yeah, that is one. The second point is, well, I thought that this question would definitely come up because in 2017, actually yours is slightly different, but in 2017, there was this issue in the Daily Mail and even the Sun about a research that had been done in America, in Harvard, I think Boston University, Harvard, and then the Harvard Medical School, Harvard School of Public Health, and then the medical school. So they had done a survey, and they have followed people up for 18 years. And they actually wanted to find out about the rate of ejaculation. So irrespective of how you do it, that's not a problem. It's just a question of when you have orgasm, how many times do you have orgasm? And they were trying to find out people who perhaps, to find out whether this can prevent, prostate cancer. As regard the sexual activity and the size of the prostate, there is no study to prove that, because just imagine it is not really feasible to do that, because you want to be measuring the size of the prostate by a scan. Using your finger to estimate the size of the prostate perhaps might not be the best, because that would be more subjective. But then you need a well-standardized instrument to do that. So there hasn't been much studies to prove that. But this particular study that I'm talking about is more in relation to ejaculations and prostate cancer, whether it could. In fact, that study did prove that actually frequent ejaculation, in fact, it was quite interesting, that I think it came as 21, if you can have 21 episodes of ejaculation per month, then you reduce your chances of having prostate cancer. But many people have torn into that study, and this is a cohort study. This is a survey. You're actually taking information from people. So they are telling you, they are working it backwards. When I was 20, when I was 30, this is how many times I was having. It's quite unreliable. So that's going to create some confounding issues in there. Who knows? Those who are quite sexually active are perhaps unlikely to go for prostate screening or to go for a check, and therefore are unlikely to know that they have prostate cancer. So to answer your question directly, there's no study that has proven that having frequent sexual activity increases the size of the prostate. So long as you've got testosterone, that is the main fact, that testosterone actually increases the size of the prostate with time. And your last question is about how frequent do you have to do that? Well, I think in my previous slide, I've said that in the UK, if you have symptoms, it's not screening. You're actually going to see the doctor for a check, whether there's any problem there. For those who don't have symptoms at 50, the guideline says that you could go to the GP to have that conversation. So you have the conversation, you have the test, everything is all right, then probably in the next 5 years, you can do a similar one. But I just want to say that for people who have a high risk, you've got a father, a brother who has got prostate cancer, you've got a sister who has got breast cancer with those chromosomal or gene abnormalities, of course, then it would be much better, to start it earlier. In fact, the advice is that you should even start at 45, to have some form of screen, maybe yearly screening test, because the travel or the increment in the prostate might tell you that there is a change, and so you can pick it up quite early. So that is what I would say on those questions.
Right. Thanks very much, Dr. Kensah. We have a question from the chat group that does vitamin D help in preventing prostate cancer amongst Black people?
Yeah, I think that has also come up in the literature about the metabolism of vitamin D and its effect, to reduce prostate cancer. But I have to say that to this point, that has not been validated. At the moment, there hasn't been any validated dietary or use of vitamin supplements or food items that has been found to reduce the risk of prostate cancer. Actually, there has been some relatively credible work that's been done about lycopenes. So these are antioxidants that are found in tomato, for instance. And then you've got selenium, which is also found in Brazil nuts. That has got some credible information that perhaps it does reduce the risk of prostate cancer. But as at now, these theories have not been validated. So no, I would say that vitamin D and then its associates, yes, they are under study. We know that people have done work about them, but we are not so certain yet that they really prevent prostate cancer.
Okay, thank you very much. Any other questions for Dr. Kensah?
My hand.
Right, okay.
My hand.
All right, please go ahead, Okay.
Right. Thank you very much, Dr. Kensah. This is excellent. One of the best medical presentations I've had the privilege of listening to. It was advertised on the Ghana Union platform in Manchester.
Right.
This is one reason why I should send my son to Koforidua to study.
You're welcome. Well done.
Mmarima Mma, one of you, but brilliant. My name is Dr. Richardson, Manchester Business School, Manchester University. Brilliant presentation.
Yeah.
I want to look at, because I want to look at the side effects. If you've got prostate cancer, local, so it's not metastasized, and there's the option of surgery, removing the whole stuff, and radiotherapy combined with hormone treatment. Of course, all treatments have side effects. Which one will be less in terms of side effect? The surgery or the combination of hormone treatment and radiotherapy?
Right, thank you. So if I understand your question clearly, you are asking about the localized prostate cancer, yes?
That's right.
Yes, okay. So when you have the localized prostate cancer, your options are 3 in terms of treatment. And the first one is going to be the active surveillance. Because we do know that most of these cancers are indolent, they are slow growing. And so you can actually monitor them. So depending on the grade, which is from the biopsy, and then the MRI scan, which tells you about the stage of the prostate cancer. That's what's going to tell you that this is localized. It is, not a very fast-growing tumor. So once you've got that, sorry, I think I've got, sorry, I'm so sorry. It's my phone. Yeah. So with the localized prostate cancer, it's either you do the surveillance to see how the progression goes. Now, the other option is also to have surgery, because that's curative. Yes, you are taking the tumor right out from the body. But that goes with a lot of complications, because the nerves, that are actually supplying the prostate, these days they are trying to, save the nerves by robotic surgery. But invariably, most of these nerves get tampered with, and that leads to the erectile dysfunction. Yes. And because the prostate has been taken away, the urethra hasn't got much support, and that's going to lead to incontinence. So actually, having the surgery comes along with quite a lot of complications, and not only to talk about incontinence, and then and perhaps you probably might have dry orgasms as well, because once the prostate is taken out, the vas deferens are clipped. And so you are not going to get much communication of sperm, running through the vas deferens to join the urethra. And so that's going to give you another wow factor as well. So the surgery comes along with, quite a lot of, but who knows? It could be that without having the surgery, this prostate cancer won't have any effect at all on you. So I think it's much better, in my opinion, to have the active surveillance, which can actually track, how the prostate cancer is behaving. What they do is that they invite you maybe twice a year to have your PSA. At the end of the year, have an MRI scan. You also have a digital rectal examination. If everything is all right, the next year, they grade it and then perhaps tail it until the active surveillance stops, or maybe the disease progresses to a different level. Then the third treatment is radiotherapy. You don't have to have surgery for the localized disease. You can have radiotherapy. Radiotherapy also comes with its own problems as well, much the same as the radical prostatectomy, because radiotherapy would can cause incontinence. It can also cause erectile dysfunction. It can lead to what we call proctitis. That means that you've got a lot of inflammation within the rectum, and that can give people a lot of hard time as well. So as it is now, if you are talking about localized disease, there's no place for hormone treatment for localized disease. You only use localized disease for the metastasis. So when it is locally advanced and you've got metastasis to other places, that's when you use the hormone or radiotherapy and chemotherapy. So three: radiotherapy, chemotherapy, and then the hormone. So yeah, for localized disease, yes, the radiotherapy and the prostatectomy carry a lot of problems.
Thank you very much, Dr. Kensah.
In order to prevent spreading, you may still have to go through that, isn't it? Through one of them.
Well, if
you have Gleason score of, say, 7 or 8, you may have to take one of them.
Yes. So if you have Gleason score of 8, that tells you that prostate cancer can be aggressive. And so that needs, close monitoring, because it has deviated from the architecture of the normal cell. Yes. So the Gleason score is just comparing that pathological cell to the normal prostate cell. And it's telling you that this is way of, it's a deviant from the other normal cells. And so you have to keep an eye on it. What is really important is to make sure that it doesn't break that barrier, that capsule of the prostate. As soon as it breaks that barrier, you are spreading, because you can have micro infiltration into all these lymphatic channels. The doctors might even not know, the test might not pick them up. It's actually said that before you have some of these cells exerting their effect, you would have had millions of those cells in the gland already. So once it's broken the capsule, it's gone into the bladder, the seminal vesicles, that's a local infiltration. And that's not good. So those are the ones that actually need the hormones. Yes, the hormone basically, what you are doing is that the hormone, there's part of the brain called the hypothalamus, and the hypothalamus produces a hormone to produce another part of the brain called anterior pituitary. That is where you have the hormones which actually influence the testes, the gonadotrophins. So they come down to, ask the testes to produce the testosterone. Now, if we give you the hormone is actually given, continuously. In the natural state, you've got this chemical that's coming from the hypothalamus, in pulsatile nature. And so that helps in the testes to produce testosterone. Once the doctors give you continuous, so every 3 months they'll ask you to come for an injection, either Zolades or the Prostate. That is continuous. That continuous injection actually switches off the production of the gonadotrophins. And so you don't have much of the testosterone. And so you actually use that as a salvage mechanism to prevent the cancer cells from spreading to other places, or if there is, to shrink them and take them out of that.
Okay, guys, we're running out of time. Do you mind if we extend the webinar beyond the advertised time of 9 o'clock?
No problem.
All right. We have a series of questions from the chat. I'll read one of them to you. It says, "Thank you, doctor. I am 48 years old. My dad died of prostate cancer last year, age 75. What would be your advice to my siblings and myself?"
Right. I think we are talking about a strong family history here. So I don't really know at what age the dad actually had prostate cancer. Actually, generally, if you got a parent or a brother who has prostate cancer, then your risk is double or triple. The other fact to this is that if they had it before 65, then that is even worse, because that tells you that the propensity of developing an abnormal prostatic cell is very high. But having said that, I would, go to the GP or my doctor to have this conversation, because you don't have any symptoms, there's nothing wrong with you. You're going to have a conversation. You are Black, you have a family history, and if it's early cancer, then that puts you in the risk category. So you have a discussion with the doctor, but recognizing that the test is not just as simple as that. It comes with its own baggage. That if it is high, will you be happy to have the biopsy? Will you be happy to have, all the intrusive treatments, which comes up with complications? So I think if your dad died at 75, yes, you could go to the GP and then have that discussion, and then make an informed decision as to what to do.
Thank you very much. We have another question from the chat. It says that is the 5-alpha reductase inhibitors side effect good for people with high blood pressure?
Yes. So the 5-alpha reductase is purely working on preventing production of the dihydrotestosterone. In fact, it's interesting that the 5-alpha reductase also are used for, in lower doses, are used for treating baldness like mine. But no, they don't have much effect on blood pressure, so that's fine, to use.
Okay. Any questions from the audience again? If not, there is another question.
Just want to find out.
Okay.
Dr. Kensah, just want to find out, in terms of the two types of testing, the digital rectal examination and the PSA, I know a lot of people want to go in for a test, but for the fact that a finger has to be stuck in there has prevented people from having it. Just finding out, is it possible you could actually request for the PSA whereby a blood test can be taken for that finding as a first choice of treatment? Or you have no option but to go in for the DRE?
I think that's a very good question. Most men have been inhibited or prevented from having assessment or just because of that DRE. And obviously, if you saw Dr. Grossfinger, obviously that would even put you off completely. But yeah, the DRE is actually it's not as good as the PSA in terms of the screening. As at now, PSA is the only thing we have, in terms of the screening, and that is the standard. DRE has got subjective implications because you got an individual who's using their feeling to say, but in very good hands is as good as anything else. Yes.
Okay.
Sorry.
Just to follow, so having to go in for the PSA, how long do you tend to get a referral? And do you go to the phlebotomist or do you go to a specialist field to actually get the PSA done?
Yeah, so with my previous slide, I showed you the things that can be done at the GP. PSA can be done. This DRE, see the GP does the DRE, the PSA test. And then if there's any abnormality, then they shift you to the hospital. So they are the gatekeeping, yes. So the PSA is just a blood test that can be done. If you want to do the PSA, or if you're about to do the PSA, you have to make sure that you haven't had any urinary tract infection, because that can increase it. You haven't had any prostatitis, which is just an infection of the prostate. You haven't had ejaculation in the last 48 hours, and perhaps exercise as well. So all those things can increase the level of the PSA. So if you want to do the PSA, it's just a blood test. You need to take those precautions so that it doesn't give you, an abnormal value. May I say also that if you were taking any of these 5-alpha reductase inhibitors, that also changes the level. In fact, it can actually reduce the PSA level by 50%. So anybody who is taking 5-alpha reductase inhibitor, if you do a PSA, it has to be doubled, to give you the true reflection of your PSA. So that is also to be taken into account if you want to do the PSA test.
Okay, thank you very much. There was a question, does taking supplements contribute to growth of prostate?
I would say no.
Good. There's a question whether you could also find the x-rays, you use x-rays to reveal the symptoms rather than do a DRE.
Right. I think when you talk about x-ray, I hope the person is not talking about MRI scan. There's no place of x-ray in the management of BPH or prostate cancer. Absolutely not.
Okay.
Even to talk about ultrasound scan hasn't got a place. Ultrasound scan hasn't got a place in investigation for prostate cancer. It's no place. You need the MRI scan. That is the most important bit, to be able to, because that gives you more detailed information. X-ray will look at bones, fluids maybe, but that's how far it goes. For soft tissues, you can't use X-ray for that. CT scan can be used. CT scan uses radiation. I have to say that MRI scan does not use radiation. So it's quite safe to use it as well.
Okay, thank you. Any other, right, PK?
Right, Mr. Host, as I said at the beginning, this is a fantastic presentation. Happily, you're recording it. Is there any possibility that we can have the opportunity to listen to it again or share with some of our colleagues who I'm sure will benefit immensely from this, but didn't have the opportunity to join us today. Is it possible?
Yeah, you're asking all the right questions. Thank you. And we must also say it's really great to have you with us. Yes, the recording will be on our website and will be available for to share with others.
Fantastic. Excellent. Thank you very much. Mmarima Mma, as I said, all my kids are big now. They can't go to school. Otherwise, maybe my grandchildren.
Right.
Super.
All right. Thank you. Any more questions for Dr. Kensah?
Yes, I have one for Dr. Kensah.
Yes, Senior Marble. Senior Marble.
Dr. Kensah,
Yes, sir.
the PSA score of 20
Yes.
and a Gleason score less than 6, what foods would you advise one to take? And not what foods would you advise one not to take?
Well, as I've said, in fact, there was a story in, well, not a story, this is reported about saw palmetto. Saw palmetto is like a palm tree. I think it's grown particularly in the southeastern USA. And some people are thinking that, by taking the berries, it actually helps in improving some of these symptoms and conditions. But as I've said, if you have BPH or you're having the voiding and the storage symptoms, it's much better to reduce stimulants. Caffeine will be one of them, to try and reduce that. Alcohol, perhaps, yes. Drinking a lot of fluid, yes. But most of these stories that are being bandied about, that vitamin D, what have you, in fact, I watched one of these presentations, and there was this person in America who could vouch that, vitamin D really prevents prostate cancer. And others also have spoken about, the other bits, the selenium and all those things that I've said. But I think once you've got the prostate cancer, if you find something that works for you, that's fine. But so far as the teaching is concerned, at the moment, most of these things have not been well calibrated or validated that they actually have any effect. But living a good lifestyle, healthy lifestyle, reducing weight, I think all these things would help, and one way or the other improve your health as a whole.
Okay, I have a question for you, Dr. Kensah. It probably is a rhetorical question. As members of Mmarima Mma UK and those who have joined us, what are the top 3 things we must do right after this webinar if we haven't paid any attention at all to prostate enlargement and prostate cancer?
Well, I think it is a prompt to read more about it and then seek more information, because the whole idea of this webinar is to improve or raise our awareness of the disease. Not only prostate cancer, but also thinking about the other disease entities of the prostate. So I think if you really haven't got anything at all, I hope that I would have challenged you enough that, well, this little stopper that is at the end of the bladder has got immense, impact on our life should it go wrong. So that would be number 1. And number 2 is that if you are within the raise or increased risk category, you probably need to be thinking ahead that, what am I supposed to do? Do I need a conversation with my own personal physician to work out, my risk? If I'm 50, or if I'm 45 with a family history of prostate cancer, is it the right time, to have that conversation, because without having a conversation, you're not going to go anywhere. And not surprisingly, 90% of Black men haven't got much information, and yet they are the ones who would have the worst form of the cancer and with the worst outcome. So I would want to use the knowledge that I have, make my own research. There's quite loads and loads of information, out there. And actually, if you use the links that I've also displayed out there, Cancer Research UK and Prostate Cancer UK, my goodness, the amount of information that they've got is just fantastic and so overwhelming. That will give you a lot of information. So yeah, you use this as a stage, to have that conversation with your doctor. And obviously, if you've got any other relations who are older, to also pass on the information to them to take good care of themselves.
Thank you very much. There's a question about tomato. Is tomato good in preventing or reducing prostate growth?
Yeah, I think I made mention about the tomato.
Yeah, okay.
Talking about the lycopene. So these are antioxidants which help, fight diseases. But yes, I've said that in fact, I in particular, I have to make a confession here that I in particular, when I came across that, every afternoon I had to eat tomato. I had to eat Brazil nuts as well. Because at that point when I read it, or came across that work, it was quite emphatic that, these actually helped in reducing prostate cancer. But unfortunately, as I've delved into it, the evidence is not so strong. So healthy eating, cut down red meat, cut down fatty food, reduce weight, exercise, eat more fruits and vegetables. I think you can't go wrong with that. Eat more oily fish as well. Okay.
There's a specific question about eating beef. Some experts say, does it increase your risk of prostate cancer?
Yeah, there has been some information about that. Red meat in particular. Red meat, as it is implicated in all sorts of conditions. But I think the whole idea is that when we eat red meat and the foods that, of course, red meat has got a lot of oil, cholesterol in it as well. So the increase in that fat content, comes along with some growth factors that we are not sure of. So an example would be an insulin growth factor, which might increase. Whether that influences, growth of prostate is another question to answer or to look into. So yes, some of these food substances, particularly red meat, not only for the prostate but general health as a whole, perhaps if it's reduced, it's better. So yes, there have been studies to suggest that eating red meat can increase your risk of having prostate cancer.
Okay, thank you very much. Are there any last urgent questions? Right, it's a question about pumpkin seeds.
Yeah. Whether it reduces, I think I've put all of them together, that there's evidence is not strong enough to recommend those. In fact, pumpkin seed is one that I've never come across that they've actually spoken about.
Okay. All right. I think that we would draw the Q&A to an end, and I would like to thank you personally, Dr. Kensah, on behalf of the group, for this wonderful, informative presentation. And I personally have learned a lot, and I shall take the actions and advice you've given us very seriously. Thank you.
Thank you very much.
We need to pass on more information to you. Right, Dr. Gand, are you there? Can you Can you hear me, Dr. Gand? Right, okay. Dr. Kensah, can you stop sharing, please? And then we will provide some more update.
All right.
For the members.
Okay. Have I stopped or not? I've paused it. Stop share. Stop share. Stop share.
Okay. All right. Okay. Right. Our next webinar will be on achieving Sustainable Development Goals in Ghana after COVID-19, collective responsibility. Dr. Ernest Foley and another old student will be giving a start. It's on the 26th of September. We have other programs also planned for October, but we'll give you those details later on. Okay. Right. We would like your feedback, please. Yeah, the link will be sent to you, and it's also on our website. And if you could please complete the survey so that we can use that as an opportunity to improve the webinar and the programs that we bring to you.
I have a quick question. So the people who are not on the Mmarima 80 chat, how do they get these the link on the document or the recording?
It will be on the Mmarima Mma UK website. So we just display the link there. So all the recordings will be there.
There are people who are not on that window platform who are attending.
No, it's for everybody. It's a general website. So the information will be there.
Okay. All right. Okay.
Okay. We can also circulate it to the various group UK platform and other platforms as well, which are the Mmarima Mma ones. Okay. Right. I think that brings us to the end of the program today. And I would like to thank everyone for your participation. And we look forward to seeing you in future. Thank you.
Thank you very much. Very beneficial.
Thank you very much.
Thank you very much. Thank you very much.
Thank you very, very, very much.
Obrigado.
Like we